Bismillahirrahmanirrahim. I'm Professor Dr. Syed Amir Gilani, working as Dean of Faculty of Allied Health Sciences at University of Lahore in Pakistan. The topic of today's discussion is ultrasound for differential diagnosis of abortion. The first abortion which we are going to discuss is threatened abortion, in which we find closed cervical loss. It is defined as a vaginal bleeding before 20th week of gestation in the setting of positive urine or blood pregnancy test with a closed cervical loss without passage of products of conception and without evidence of fetal or embryonic device. The bleeding is sometimes accompanied by abdominal cramps, and these symptoms indicate that a miscarriage is possible, which is why the condition is known as threatened abortion or threatened miscarriage. That is, there is threat of abortion or miscarriage. Vaginal bleeding is fairly common among pregnant women. A closed cervix can sometimes happen temporarily during part of each menstrual cycle. Other times, the cervix may always seem to be closed, and this is known as cervical stenosis. It happens when the os becomes unusually narrow or completely blocked off. So the patient will have cramps, closed cervical os with vaginal bleeding, and with a history of positive urine or blood test for pregnancy. The typical clinical and sonographic findings of the threatened abortion. Let's see it again. A vaginal bleeding, clots rarely, and closed cervical os on ultrasound. The serological HCG levels normal exponential rise, and on ultrasound there will be embryo with cardiac activity, empty gestational sac which is 5 to 6.5 weeks that subsequently develops embryo with cardiac activity. Then is complete abortion, but the typical clinical and sonographic findings of abnormal intrauterine pregnancy. Before we go to it, let's discuss what is the meaning of intrauterine pregnancy. The intrauterine pregnancy is defined as a gestational sac that contains either a yolk sac or a fetal bole. We can scan the patient longitudinally and transversely by using TVS transducer and look for a gestational sac and try to find out a clear yolk sac. If we get intrauterine gestational sac with a yolk sac and embryonic parts, then it is definitive of intrauterine pregnancy. Then comes another question that how intrauterine pregnancy can be differentiated from an abnormal intrauterine pregnancy. So how can we differentiate between normal and abnormal? That depends upon the viability. If we can find the cardiac flicker, this is a normal finding very early in pregnancy. But if you are further along in the pregnancy, it may mean that the pregnancy has unfortunately failed if we don't find it. It is usual to be offered a further scan in 7 to 14 days to confirm the viability of the pregnancy. Then is the complete abortion, which is an abnormal outcome. The clinical signs will be the complete passage of embryo and gestational tissues. There is a rapid fall in the beta hCG levels and the uterus will be empty. So all the contents of conception, including the gestational sac, amniotic fluid, embryo, yolk sac, everything has passed out. That means complete miscarriage or abortion. Then is the incomplete abortion. It is the partial loss of products of conception within the first 20 weeks. Incomplete abortion usually presents with moderate to severe vaginal bleeding, which may be associated with lower abdominal or pelvic pain. Beta hCG will fall, but it will be slow fall or plateau. Typically, thickened and irregular endometrium or fluid within endometrial cavity is seen. So it will be irregular endometrium. We can find some blood or fluid in the endometrium, which shows that there is some part of the gestational sac or the tissues are there. Another outcome which is abnormal is called abortion in progress. There will be bleeding, often with clots and uterine cramps. There will be variable, usually plateau of the beta hCG on ultrasound. Gestational sac in the process of expulsion is seen. So spontaneous abortion is very important. There are many factors which are the possible causes of spontaneous abortion. Again, spontaneous abortion is a pregnancy loss before 20 weeks of gestation. Approximately half of the miscarriages are due to unknown genetic abnormalities, alcohol or drug use, infections, chronic disease, environmental exposures, structural uterine abnormalities are other important risks. So we can have fetal factors which are chromosomal abnormalities and anomalies, endocrine factors which are the diabetes, luteal phase deficiency, thyroid disorders. Then we can have immunological factors and infections. Then comes the early pregnancy failure, which can be accompanied by subchorionic hematoma or missed abortion or due to blighted ovum or gestational trophoblastic disease. Let's discuss these four causes one by one. Subchorionic hematoma can be a subchorionic hematoma, which is a cause of miscarriage. On ultrasound, we can detect subchorionic hematoma, which increases the size of miscarriage in patients with vaginal bleeding and threatened abortion during the first 20 weeks of gestation. However, it does not affect the pregnancy outcome by years of ongoing pregnancies. Here you can see a gestational sac with the hematoma. This is subchorionic hematoma. Here will be the chorion. So echo-free area between the membrane and the uterine wall. The intrauterine hematomas, we can have about 62% of uterine bleeding. It is according one of the study which was published in 1984. If the hematoma, intrauterine hematoma, is above 50% or above 50 ml, the abortion or premature delivery can occur. If it is less than 35 ml, there will be abnormal outcome, whereas if it is less than 16 ml, not indicative of any TMC. This is according to two studies. The subchorionic hematoma can be fundal or it can be supra cervical. If it is supracervical, will easily be drained, whereas if it is fundal, it can cause more problem. Here you can see a fundal one, a large hematoma which can push the gestational sac, which can result in miscarriage. The subchorionic hematomas can have reabsorption, so there will be normal indices, whereas if it causes compression of the spiral arteries, lumen, there will be, we can get uh, increased resistance or decreased flow. This is a case with hematoma appearance on the diastolic flow. This is the flow and then is the hematoma. There will be no flow in the hematoma because it is a blood clot. Sometimes we have to differentiate between hematoma, which is subchorionic hematoma or a blighted ovum or blighted twin. For instance, if this is twin pregnancy, we can have a live embryo, a normal intrauterine pregnancy, along with the blighted ovum, which is called blighted twin. So, how we differentiate between a blighted twin and a subchorionic hematoma? If we get echogenic ring, thick wall separating the gestational sacs, it can be dichorionic gestation. But a blighted ovum, which is also called anembryonic pregnancy, occurs when an early embryo never develops or stops developing, is reabsorbed, and leaves an empty gestational sac. The reason this occurs is often unknown, but it may be due to chromosomal abnormality in the fertilized egg. The blighted ovum, if it is alone, not with a twin normal pregnancy, the production of pregnancy associated proteins is not dependent on the presence of the embryo, so it can grow. Typical clinical and sonographic findings of abnormal intrauterine pregnancies. Abnormal outcome. One of the abnormal outcomes are blighted ovum, which is also called an embryonic pregnancy. There will be lack of uterine growth, absent fetal heart tones when expected. The beta HCG levels will be variable. Initial normal rise, then plateau or fall, and there will be discrepancy in gestational sac and embryonic development with little or no embryonic remnants. Here is a blighted ovum, and this is increased intravenous circulation showing pregnancy. Another blighted ovum, decreased RI within the intravenous spaces, intrauterine pregnancy, the cardiac activity is present, but in blighted ovum there will be no embryo or yolk sac. Then comes missed abortion. On ultrasound, the diagnosis will be possible, but placental hormones or protein measurements don't improve the diagnosis. The typical clinical and sonographic findings of abnormal intrauterine pregnancy, there will be lack of uterine growth, absent fetal heart tones when expected, and there will be variable initial normal rise, then plateau or fall. On ultrasound, there will be discrete embryo lacking cardiac activity. Here is the missed abortion, the flow with the spiral arteries, and then is the increased RI within the intervillous spaces. Missed abortion is a non-viable intrauterine pregnancy that has been retained with the uterus without spontaneous abortion. Typically, no symptoms exist beside amenorrhea, and the patient finds out that the pregnancy stopped developing earlier when a fetal heartbeat is not observed or heard at the appropriate time. So yolk sac vascularity visualization rate is 18.4%. In missed abortion, there will be no detectable vascularity. Yolk sac diameter will be less than 2.5 millimeters. Increased echogenicity and posterior shadowing is seen. In missed abortion, there will be inadequate yolk sac vascularity, intravillous space, numerous color-coded areas due to inadequate drainage. Then comes the gestational trophoblastic disease. The diagnostic modalities are the pelvic angiography, real-time B mode, magnetic resonance imaging, which is MRI, transvaginal color Doppler with pulse Doppler on ultrasound. This is the snowstorm appearance of trophoblastic disease. This is here it is the cystic areas. In case of invasive mole, we can use the Dopplers to see the vascularity and resistive index. The gestational trophoblastic disease is a group of rare diseases in which abnormal trophoblastic cells grow inside the uterus after conception. In gestational trophoblastic disease, a tumor develops inside the uterus from the tissues that form after conception. The joining of sperm and egg is called conception. So uteroplacental blood vessels then we will have low impedance. Impedance is the resistance to blood flow. There will be complete, we can have complete mole, we can have invasive mole and choriocarcinoma. The sonographic findings of gestational sac associated with abnormal intrauterine pregnancy include in embryos absence of cardiac motion, in embryos 5 mm or larger, absence of cardiac motion after 6.5 menstrual week. Yolk sac and amnion, large yolk sac and amnion without a visible embryo, calcified yolk sac is seen. The large gestational sac, lack of living embryo and lacking of visible yolk sac. These are the sonographic findings of gestational sac associated with abnormal intrauterine pregnancy. You can see the irregular areas, and this is the thickening, which is the trophoblastic change, which can be labeled as partial mole. Here is the intravillous blood flow, the spiral arteries flow. So the gestational sac growth of almost less than 0.6 mm per day, then is the absent embryonic growth. There will be discrepancy in sac size with beta HCG levels. On color Doppler studies, we can detect patients with altered spiral artery blood flow at the site of subchorionic hematoma who are at increased risk for spontaneous abortion. With this, thank you very much. Thank you for your time. Stay blessed.